I think we have mentioned already, all of us, quite a bit about sequential analysis, one way or another, during the course. And although we came right at the end of the day, I think one would have hoped that some of you would have read about, because you're a very advanced group, so you would be interested and you would have heard already about sequential anatomy and situs abnormalities. I was actually asked to concentrate mainly on situs, so with 20 minutes we have to concentrate on something because it will be very rushed. It's going to be a bit rushed towards the end. I think for many people, when you talk about complex cardiac abnormalities, it looks like a puzzle where the pieces are not quite put together. And you look at the heart and you say, oh gosh, what is this? So the thing to do is not to panic. Try and look at it in a sequential way, having a method to allow you to describe the heart in a way that you'll be able to put those pieces of the puzzle together and hopefully understand what's happening. And that's the diagnostic approach that we use, a lot of people use. It's not universal, but across the world, many people would use a sequential segmental analysis in congenital heart disease. And basically, it's to be able to describe simple abnormalities, but also to describe very complex defects. You might say, well, why use that if you have a simple VST? Well, it's not that important, but cardiac abnormalities sometimes are very complicated. So the approach is basically based on most cardiac lesions are simple, really. And complex lesions are just a combination of lots of simple malformations. So if you combine them in different ways, you then have complicated diagnosis. So that if you approach the heart in a logical way, and then all those complicated abnormalities will become simple. But it is therefore necessary that people understand what the terminology means, because this is something that was created, it's man-made. So it's defined terminology, and unless you know the meaning, and then it's difficult to follow the segmental approach. But basically, it's based on studying the heart as various segments, and if you think of them as different pieces of the puzzle that can be muddled in the most disorganized way. And by looking at them sequentially, you can impose a certain process of analysis that hopefully will minimize any errors in making the diagnosis. And then hopefully you will be able to come to a diagnosis that can't be summarized like a ventricular septal defect. This is a whole list of diagnoses in one fetus with asplenia, for example. And you have to be able to describe everything so you can follow the pathophysiology of the abnormality. I'm not going to go through all of that. So sequential analysis was described many years ago, at least the approach to children. And although we started initially in the United States, it kind of has taken over here in the UK. And I'm glad to say that it is based primarily on the anatomy, which is good for us because that's what we're looking on ultrasound and not on the embryology. So it's what you look that you describe. So you need, therefore, to know the morphological features of the heart to be able to recognize the various structures. And then we move on to connections and relations in this space. So the various cardiac segments, so you kind of dismantle the heart into the atrial chambers, the ventricular chambers, and the arterial trunks, the aorta and pulmonary artery. And you also look at the connections on how those come together at atrioventricular junction and the ventricular arterial junction. And the situs, really, when we talk about the heart, relates to the atria. Situs just means position, and you can have situs of the viscera, situs of the lungs, of the bronchi, and when we come to the heart, situs will be related to the arrangement of the atrial chambers. And then we will come back to the situs. In the sequential analysis, we'll be looking at connections, which is how those pieces are put together and their relations in space. So to try and understand a difference between connections and relations, I'm just going to use some interesting pictures here. In here we have everything connected in the normal way. Yeah, it's the head of a girl, it's the body of a girl, it's the legs of a girl, but they're all over the place. So the relationships of the various structures is wrong. So you can have your aorta connected to your left ventricle, but in a different position. So it will be a normal connection, but an abnormal relation. Then here you have abnormal connections, but the relations are normal. But you have a head of a fish with the body of a human. And that speaks for itself, is a muddle, abnormal connections and abnormal relations. Also, in sequential analysis for the child, it's very easy. You look at the child and you know this is the right and this is the left side of the child. You don't have to work out anything. But in the fetus, if you can see this here, these are all human bodies in all sorts of positions. It'll be very difficult if you look at that and straight away tell me which is the right and the left side of these various people. So the same for the fetus. It's very easy to work it out, but you do need to establish fetal laterality and which way the baby is lying and work out right and left. And that's the basics. You have to do that in the fetus, determine which is the right and the left side, and then move on to situs after that. So fetal laterality, and then after that, we then start with the sequential analysis that we use in the child, determining the situs, the atrioventricular connection, the ventricular arterial connection, and then you start listing all the associated abnormalities and their spatial relationships. So we come back to our diagram, and we're going to start with the atria, which is looking at situs. So situs or atrial arrangement, that is, where are the two atria? And this is an anatomical specimen cut across the level of the appendage. So you have the atrial chambers, and each one has an appendix. And this is the right-sided one, which is broad, heavily trabeculated, and the left-side one is rather thin, with a narrow neck and much less trabeculation. So they are different. Although there are two atria, they have different atrial appendages. And although we can see that in the fetus, it's not always possible. Nor in the child. We don't go usually scanning a child looking for the morphology of the appendage. And in this case here, we can see, having established that this is the right side and this is the left side of the baby, you can see a right atrial appendage and a left atrial rather narrow. But on a day-to-day basis, and it's much more simple to do, one looks at the situs in the abdomen. So that's when we say take your AC, your abdominal circumference, check right and left of the baby, and make sure that the position of the stomach, liver, the aorta, and the inferior vena cava are as you expect. And usually, not always, but pretty much 100%, the arrangement in the abdomen will reflect the arrangement of the atrial chamber, so you don't have to spend a lot of time trying to define which atrium is which. So that's why we start looking at the heart from the abdomen, and that's why that's incorporated into this stick and is incorporated into the normal scanning. So what we call situs solitus, or the usual arrangement of the atria, and the usual arrangement is we have a right atrium on the right and the left atrium on the left. So we start to put those pieces of the puzzle together on the top, two atria. And if in the abdomen you have your normal, the stomach to the left, the liver to the right, the aorta to the left of the spine, and the IVC or inferior vena cava to the right, that's the usual arrangement of the vessels and the viscera in the abdomen. So you can pretty much confidently assume that the two atria are like that. Your right atrium is to the right and your left atrium is to the left. And of course, there is the mirror image arrangement of that, which is situs inversus. And situs inversus mirror image is basically just the opposite. And it's very important to realize here that if you don't label right and left, this image here will be the same on the screen, be it situs solitus, normal, or inversus. The only difference is when you work out right and left of the baby, you realize that in this situs solitus, the stomach is left side, and in this one here, the stomach is right side, and that's obviously dependent on fetal position. But otherwise, the picture is absolutely the same. You can label them in any way. So very important to determine laterality. So we have two more possibilities. So there are four possibilities of situs: normal, solitus, inversus, like a mirror image, and we have two groups of situs which are usually associated with very complicated abnormalities. And those are the group of heterotaxy, polysplenia, asplenia, or as cardiologists we tend to call them right atrial isomerism and left atrial isomerism. And isomerism comes from chemistry, where you can have compounds which are mirror images of each other. So as far as the heart is concerned, you would have two atrial chambers, and this is obviously a composite image. They're not quite absolutely the same, but in here you'd have one right atrial appendage and a second right atrial appendage, which means the two atria are right atrium in morphology. And the same applies for left atrial isomerism, where we would have two atrium in which the appendage have the morphology of the left atrium. And that's starting already disrupting the heart quite a lot, and most of the time, particularly in right isomerism, that is followed by a combination of quite a lot of complicated abnormalities. So how do we see this in the abdomen? So coming back again to our abdominal view at the level of the AC, you have to determine which is right and left. And in this particular case, we have a left side here. We have the stomach there, the aorta, and the inferior vena cava. And if you trace a line here dividing it, they are both on the same side of the spine. So right atrial isomerism, we have the aorta and the inferior vena cava to the same side of the spine. It doesn't have to be on the right, it could be on the left, so it could be either side, but they are more or less close together. The stomach is usually rather small and rather central as well, and it could be right-sided or left-sided. It doesn't matter. Sometimes you have a portal vein going to the same side of the stomach because the liver is kind of rather midline structure. So there is a muddle in the abdominal organs as well as the cardiac structures. So you imply the atrial chambers from here, and you can almost guess what the combination of cardiac abnormalities are going to be, which is similar to that long list I gave you. For left atrial isomerism, that is associated with, in most cases, not always, an interruption of the inferior vena cava, so you don't see the IVC, but you see an azygous continuation or an hemiazygous. So basically you have an aorta which is quite often rather in the middle, rather central position, and either to the right or to the left, it doesn't matter, it could be either side, you see behind the aorta a vein which is posterior, which is the continuation of the IVC, which doesn't exist above the liver. And then if you see that, you again can start to imagine what's going to be coming in the heart in terms of abnormalities. So this is a magnified image of the isomerism. And you can see here, this is a real position of the babies, yeah? This baby was head down, spine here, so this is the right side. So if I take those lines, one could look at that and say, well, this is normal. But actually you need to look at everything very carefully because the stomach is to the right. And if you really trace the midline here, you see that both the aorta and the inferior vena cava are to the same side of the spine. So this is a case of right isomerism. And this is usually complicated cardiac abnormalities. This is the same, and it's just a plain image. You can see if you forget the labels there, you could actually say, well, this is, normal. But if only you calculate work out the baby's position, and then you work out that stomach is in the wrong side. You don't even need to see the other thing. A stomach on the right side shouldn't be there. That is going to be a problem one way or another. So that's how we make the diagnosis of right isomerism. Then we come to left isomerism, again dividing the abdomen here in the midline, and we have an aorta in a rather central position in relation to the spine, and a posterior vein. As I said, it could be to the left and it could be to the right. In this particular case, the stomach is left side. So more or less half-half. The stomach in both forms of isomerism can be to the right or to the left. Sometimes the portal veins to the same side of the stomach, sometimes to the other side, and they can be anywhere. And of course, in the left isomerism, when you come to longitudinal, sagittal view of the fetus, quite often you can see the two of them together. If you look for them, you'll see because they're very close together, and you can image the aorta going down the abdomen, the azygos coming up either to a right or a left superior vena cava. Interestingly, although we don't have an inferior vena cava where the ductus venosus joins to, you can usually get the ductus venosus signal, which is a continuation of the umbilical vein towards the kind of hepatic venous confluence. Because we don't have an inferior vena cava, the hepatic veins, they drain directly into the atrial chambers, but it's usually possible to get the ductus venosus signal even if you don't have an IVC, just out of interest. And although most of isomerism are associated with very complicated abnormalities, you can have, particularly in left isomerism, the heart that is otherwise almost normal in terms of the physiology. And this is an example of a case that was seen by a colleague of mine recently, diagnosed of an atrioventricular septal defect. The stomach was in normal position, everything, karyotype normal, and later on it was then observed that there was here behind the aorta, which wasn't appreciated early on, there was an azygos vein, and these had typical features of left isomerism with an atrioventricular septal defect. And in this case, you would expect the karyotype to be normal. So small details sometimes provide a lot of information. This is another example of left isomerism, and because we have two left atrium, there is a disruption as well of the conduction system. You don't have a proper sinus node because that's usually in the right atrium. So rhythm abnormalities are common. And in fact, this lady here, she was referred because they thought the baby had transposition. And in fact, there was ventricular arterial discordance, which is transposition. But on top of that, the ventricles were in the wrong position. There was an azygos vein with interrupted IVC. And so it's much more than just transposition. And 2 weeks later, the baby developed a second-degree heart block, which is a risk that these babies can happen to them. As you can see here, the heart rate was slow. It was about 80. Fortunately, this baby did well and did not progress to third-degree block. So that's more or less a summary of situs, which is what we should be concentrating most on these. And we don't have much more time, but I'm just going to list the other things here. And this is also on your CD, so don't spend too much time trying to copy it all. You have it on your PDF files. So then, once we establish the atrial, we still need to connect everything else. And I'm just going to go through these relatively quickly because we don't have time to go into details of all of them. So we have 4 possibilities for situs. For atrioventricular connection, we have 2 groups. Either we have biventricular connection or we have a univentricular connection. I'm not talking here about univentricular hearts, which is what Lindsay Alla has struck from her talk. Yeah, we're talking about univentricular connection, not a univentricular heart. So for biventricular connection, there are 3 possibilities. It's concordant, discordant, or ambiguous. And for the univentricular connection, again, we have 3 possibilities. An absent right, an absent left connection, or double inlet ventricle. So we're going to start with the biventricular connection. Concordant is the normal. And that basically means we have the right atrium. We know where the right atrium is now because of the situs. Right atrium connected to a right ventricle. And therefore we need to be able to recognize the right ventricle and distinguish it from the left by the moderator band, the offset of the valve. So right atrium to a right ventricle, and it's very important to remember the end, a left atrium to a left ventricle. So that's the normal. Then we have a discordant atrioventricular connection, which means you have your right atrium, it doesn't matter where it is, to the right or to the left, but it's the connection, the plugging of the right atrium to the ventricle. So right atrium to a left ventricle and a left atrium to a right ventricle. So we have a ventricular inversion. You need to have the 2 of them. So right and left. So to have concordant or discordant, we need to have a right and a left atrium. In the case when we have isomerism, which are the complicated ones, we don't have a right and a left atrium. We either have 2 right atrium or 2 left atrium. So the connection can't be concordant or discordant. So we just describe it as ambiguous with the 2 ventricles, and then basically we just list where is the right ventricle. Is the right ventricle to the right or to the left? So it becomes very easy because you just describe what you're seeing, and then everybody understands what it is. Now, this was the case of left isomerism, where the defect was only a primum ASD, and in this case, the right ventricle was to the right and the left ventricle to the left. And that clarifies, so you can continue putting your pieces of the puzzle together. Then we come to the univentricular connection, and the possibilities, as I said, are three: the double inlet, the absent right and absent left. And the double inlet, basically the two atrial chambers are connected to mainly one ventricular mass. Usually there is a second ventricle, and we have either two separate valves here, but we can also have a common valve, so it doesn't have to be two separate valves. An absent right connection is when the atrium on the right is not in continuity, is not in communication with the ventricular mass, and you have this sulcus tissue here, a big lump of fibrous tissue between the atrial chamber and the ventricular mass. So if it's on the right, it's absent right. If it's on the left, it's absent left connection. Absent left connection in situs solitus is microatresia. Absent right connection in situs solitus is tricuspid atresia. But remember, we don't have to have situs solitus to have these absent connections. You could have situs inversus with connection, and then it's when things start getting complicated. So now we're going to move on to the connection of the plumbing of the ventricles to the great arteries. And some of the terminology is the same to make it easy. It's either concordant, discordant, double outlet, or single outlet. So it makes sense, and we've already mentioned quite a lot of this throughout the day. So concordant connection is the normal. Your right ventricle is connected to the pulmonary artery, and so we have to have the two. The left ventricle is connected to the aorta. That's normal. It's what we see in most cases that we scan. Then we have the discordant ventricular arterial connection, when the right ventricle connects to the aorta and the left ventricle connects to the pulmonary artery. And remember from the lecture on overriding, if you have overriding, where do you put that vessel? You put that vessel to the ventricle to which is connected to at least 50%. Yeah? So you can define if it is attached to the right or to the left ventricle. Then we have double outlet ventricle. And double outlet is a terminology that's used a lot. People say, what's the diagnosis, double outlet? Well, double outlet doesn't tell you much more, just telling two vessels are coming off the same ventricle. So you have to specify double outlet right ventricle, which is the usual. It's very rare to have double outlet left ventricle. But not only that, one needs to see where the VSD is in relation to the great arteries. And there are two types of double outlet, two main types. There are other ones that I'm not going to go into details now. But you can have a subpulmonary VSD, and that's very similar to tetralogy, to transposition. And we have one with a subaortic VSD, which is very similar to just a ventricular septal defect. So in the subpulmonary VSD, which is what we see here, the two vessels coming off the right ventricle and the aorta is in a kind of transposed position. And then we have single outlet, and the commonest, or the most sort of important in that is truncus arteriosus, one vessel that then divides, as we've gone through that earlier on. But you can also have one vessel being a big aorta with pulmonary atresia, we've seen that as well, or you can have one big vessel coming with aortic atresia. So it seems maybe at the end of the 2 days that this is a bit too complicated. But the hearts, they don't care, when they're formed. They come in all sorts of muddle. And unless we can impose some kind of structure and start putting all of those together, we're never going to be able to make that very long list of diagnoses I've seen earlier on. And that's important in terms of predicting how the blood is going round, what type of operation is going to have, and prognosis. A lot of this is in a rather compact way described in an editorial from a few years ago, and a lot of these pictures are from that editorial as well. So hopefully, if one knows what the terminology means and imposes that structured way of looking at the whole heart, at the end of the day, you'll be able to put the pieces together and hopefully come up with an accurate diagnosis of simple as well as complicated heart abnormalities. Thank you very much.